Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I'm joined by Professors Ricard Cervera and Ronald van Vollenhoven from the Lupus Academy Steering Committee, who will be providing expert views on the hot topics presented at the EULAR 2025 Congress in Barcelona mid-June. Ronald and Ricard, welcome and thank you so much for joining us today. So the EULAR Congress this year was held in Barcelona, mid-June. Groundbreaking research and clinical insights were presented in every field of rheumatology, but for the purpose of this podcast discussion, we are going to go in depth with systemic lupus erythematosus and lupus nephritis news. So, Ronald and Ricard, first, what were the highlights of the meeting that you want to make a little summary? Ronald, can we start with you?
Well, thank you very much, Raquel. And it's always nice to reflect back on a big international congress. These are always very enjoyable events. And then in the beautiful city of Barcelona, it was obviously a delight to be there, but also to be together with almost 14,000 colleagues, including other specialists and also patients, including researchers and practicing physicians, including trainees, and some very senior people. So, you know, it's very enjoyable to have the interactions. And if it comes to lupus, it was a particularly happy occasion because so much is happening. So we're seeing tremendous developments, both in terms of our understanding of the disease, understanding its impact, what it means to the patient. And here, again, the participation of the patients was very important and fruitful. Mm-hmm. And then also all the things that are happening when it comes to treatments and how treatments are being developed, are coming to fruition, and are really opening up, the possibility of very much more improved possibilities for treating the disease in the future.
Thank you. Ricard, what is your summary of the Congress that was held in your city? So.
That's right. Certainly I have a conflict of interest because the meeting was in my city, in Barcelona. It was sunny days, and we were really very proud to welcome over nearly 14,000 delegates from 130 countries who visited 177 scientific sessions and view more than 1,500 posters. So there were record figures of activities in this EULAR Congress.
Yeah. So let's start discussing some of the presented works. Ronald, on clinical strategies, one of the presenting abstracts was the defining safe hydroxychloroquine blood levels, enhancing lupus management through precision monitoring. What are your comments on this work?
Yes, this was a very interesting approach that's not completely new. There's been some analyses of these in the literature, but what is now coming to the forefront is that when you treat with hydroxychloroquine, you would like to have the optimal effect, which is a dose-dependent effect. So you would like to get the highest possible dosage to the patient. But at the same time, you're also aware that there are some side effects. Fortunately, it's generally a very safe treatment. But the main risk that is always referred to is the retinopathy, which is related to the dosage, but also cumulative dosage. Mm-hmm. And at any rate, it's somehow related to the fact that if you get excessive serum levels, they will be deposited in some tissues, including the retinal tissue. And so what Jay Garg and other investigators did here was that they looked not just at the dosage that we're giving the patient, but what is the blood level of hydroxychloroquine. And then you can try to see the relationships between the blood level of hydroxychloroquine on the one hand and the beneficial effects on the other hand, and also the toxicities, side effects on the other hand. And these are complicated studies to do because they involve longitudinal follow-up, quite long timelines. So I think they deserve a lot of credit for having analyzed this in large data sets that included patient follow-up for many years and also samples. And what they found was that there is a very good correlation between the levels and finding the optimal balance of efficacy and safety. And so what they're suggesting is that you could use these measurements of the blood for targeting or for getting the right dosage to the patient. Now, in this particular work, they also specifically looked at patients with chronic kidney disease, because of course then we know that there's going to be a change in the clearance. And at any rate, I think their data, together with other data that were already published or are in the public domain, would say that maybe in the future, when we treat with hydroxychloroquine, we shouldn't so much go by milligram per kilogram or something like that, which is what we're doing now, but that we could do it by measuring blood levels. I think we're not quite there yet, but I think will become something to implement in the coming years.
Thank you. Are you measuring in your center the hydroxychloroquine levels?
No, we are not.
Okay. Ricard, are you measuring hydroxychloroquine levels?
No, not as a routine. We have done this in different research projects, but it is not our routine practice.
We still have to find a way of doing it, normalizing it. Ricard, still on clinical practice, Ed Vital presented the task force for the consensus-based guidance for glucocorticoid tapering in patients with systemic lupus. How do you feel that these guidelines that had an amount work and a task force differs from your current clinical practice?
Well, first of all, I have to say that, as it is said, all rockers never die. And in this time of these new CAR-T therapies, or the new monoclonal antibodies, the small molecules, and so on, the old rockers are hydroxychloroquine. Ron presented the previous the previous study, and glucocorticoids. And certainly this consensus-based guidance probably will support physicians in choosing a glucocorticoid tapering approach for patients with lupus across different clinical scenarios, and will help them to use glucocorticoids more efficiently. Well, I think that the next step for this guidance is to attain also the patient's perspective on these results. We ensure really that the patient preferences are considered when initiating this glucocorticoid tapering. And also, it is very, very important, the dissemination into the routine practice of these different tapering guidance.
Thank you. We have heard on the previous years that one study, namely the French study, that tapering it too shortly would probably induce flares. So it's very good to have a task force that would help to guide the tapering of steroids. Then, of course, it has to be adapted to each country. For example, in Portugal, we don't have 1 milligram prednisolone pills. We only have 5. So it is kind of a challenge to do the tapering after that. Thank you so much. Ronald, there was a presentation of the lupus arthritis composite score of musculoskeletal ultrasound findings that could be used on prospective intervention. What are your comments on this score?
Well, I was very intrigued by this, because we are, of course, with lupus, we are often looking at individual organ systems that are involved in lupus, that are affected, and where the patient is having symptoms, and then we try to quantify it. So, for example, the skin, it can definitely be affected by lupus, and there is a scoring system that's called the CLASI, which can actually give you a number on the activity and the severity of the cutaneous lupus manifestation. Same thing, of course, for the renal manifestation, lupus nephritis. We know how to quantify it. We measure proteinuria, we measure kidney function by the GFR, so we get a number. Now, when it comes to the lupus arthritis, the musculoskeletal involvement of lupus, you would think that we could also quantify it, because in other diseases such as rheumatoid arthritis or psoriatic arthritis, we quantify this all the time. We take the joint counts, the 28 joint count or the 68 joint count, and then we measure swollen joints and tender joints, and we do this almost routinely in those diseases, and it gives us very useful numbers to work with in practice or in research. Now, the strange thing is that for lupus arthritis, that hasn't worked so well. There are some attempts, and there have been some studies with that. And it comes down to the fact that lupus arthritis, even though it can be very painful and certainly for the patient quite serious, is nevertheless not so very clear to the clinical eye. The swelling is usually not so extensive. Effusions are not seen so often. So it is a little bit harder to quantify it. And also the fact is that the manifestations differ more between the patients. So it's been hard to come up with a very solid scoring system for lupus arthritis. And that's why some people said, well, okay, if we can't do it by the physician's assessment, maybe we can do it by some form of imaging. And of course, ultrasound very much comes to mind. Ultrasound has already been investigated previously, of course. And in lupus, there are some data that also show that if a patient has the joint involvement of lupus, you can actually look at it with ultrasound and you can see it there. And so what the investigators here did in what was an oral presentation at the EULAR Congress, they said, okay, let's try to quantify it based on the ultrasound, because maybe that will give us the actual numbers that are going to be so useful if you then want to follow the treatment over time, or if you want to see in a trial if a drug is working, then you can get these actual numbers. And they developed this scoring system called LAMDA. And from the data that were presented here, it has a lot of promise for doing just that.
Okay, so we might have another score to measure on the next trials.
Well, that's what I think will happen. So I think it will, as these things usually go, this group of investigators will probably keep testing it in smaller cohorts. Maybe others will do the same thing, but it may be included in some clinical trials as a secondary or exploratory outcome.
Yes.
And then if the results are convincing, it will gradually become more established. So this is a longer term prospect, but I do think it will work in the future.
Perfect. Let's move to lupus nephritis, and we selected one of the presentations, one of the poster presentations. Ricard, what were the news presented on the REGENCY trial on the kidney-related outcomes that Richard Fury presented?
Well, as you know, the REGENCY trial was the trial that demonstrated finally the efficacy of anti-CD20, the humanized anti-CD20 obinutuzumab in lupus nephritis. After the failure of the previous anti-CD20 drugs, rituximab or belimumab, finally we got a humanized anti-CD20 that was demonstrated that the efficacy. We had this good news recently, and this additional study that was presented by Richie Fury in the EULAR Congress, this was a pre-specified exploratory analysis of this REGENCY study, and demonstrated that obinutuzumab also significantly reduced the occurrence of lupus nephritis flares, and also other unfavorable kidney outcomes, and also attenuated the annualized decline in the kidney function compared with placebo-treated patients that were the standard of care. So this, together with the previously data that we already know that there was a significant higher proportion of patients achieving a complete renal response in the obinutuzumab arm, certainly we believe that these findings suggest that obinutuzumab affords long-term kidney survival benefits compared with the standard therapy. We all have great expectations that probably this will lead to the final approval of this anti-CD20 therapy for lupus nephritis.
So we're going to have not a dilemma, but probably a trilemma when to decide what are going to be the combinations on lupus nephritis. Do you have any comment on that, Ronald?
No, but I think it's right on target to say that we're going to actually have several choices for patients with lupus nephritis. Part of it is that we will already have the combinations that are approved now, for example, the addition of belimumab or of voclosporin to the existing standard therapy, which is in most cases mycophenolate, could actually be Lupus also. There are data from Southeast Asia about the use of tacrolimus in that setting, although not approved for it. And then I think obinutuzumab, indeed, as Richard was also saying, that will most likely be approved for use in that same situation. And so then suddenly we have several different possibilities. And how do we choose? You know, is there a patient profile that will help us decide? Can we even combine several of these possibilities? We don't know. So there's still a lot of things to be discovered about this, but I think the prospect for patients with lupus nephritis will gradually improve as a result.
Yes, this is really amazing. And talking about drugs that are already available, and we still have more data to share its usage. So, Ronald, there was a post-hoc analysis that exclude the glucocorticoid component on the 5 phase 3 trials of belimumab. What do you think is the most relevant data of this presentation?
Well, so where this comes from, and this was an analysis done very, very well by Yannis Parodis from the Karolinska Institute, but I had the opportunity to support it. And so where it comes from is that if you look in clinical trials, for example, with belimumab or with anifrolumab, which are, of course, approved for the treatment of lupus in general, and then you ask yourself the question, okay, so how many patients achieved the low disease activity level that is defined by the LLDS, or how many patients achieved remission, which is, of course, the goal that we all would like to see for our patients. And we can be defined with DORIS. And then actually, if you look at those percentages, they're quite low. And you could be disappointed and say, oh, in these trials with these drugs, there are even approved drugs, but the percentage of patients who are achieving LLDS or DORIS are not so high. How can it be? And it turns out that, well, in part it is because the trials will have patients on steroids when they come in. And the trials may not actually require the patients to try to taper the steroids. They may allow the patients to stay on the steroids. And the definitions of LLDS and of DORIS, they put an upper limit on how much prednisone or equivalent you can have. So what happens is that the patient is actually doing really well, and they feel good, and the doctor is happy, and the patient is happy, but they keep on taking the prednisone, and so they do not meet the definition. So they're not counted as a patient who's in remission. So Yannis Parodis and others, we said, okay, let's look at it in more detail. And if you then disregard the steroid component of these definitions, you get much better numbers, obviously, because then some patients are now considered to be in remission or in low disease activity. But in this case, that may also be more truthful. That may actually reflect reality in a better way, because then the patient is in fact doing really well. And in the future, they will probably be able to also taper the steroids or even be completely without. So I think in this case, it tells us a little bit more of an optimistic message that many patients, more patients than we thought, are doing really well with these treatments.
Even if they are not yet on the target steroids tapering. But there's a way. Thank you. And we also heard the presentation of Zaitumab on the data on long-term damage of anifrolumab use versus real-world standard of care. Richard, what are your insights from this large presentation?
Well, nowadays, one of the key challenges in lupus is what is called the modification of the disease, and to find disease-modifying drugs. And thanks to a group led by Ron van Vollenhoven, we now have some criteria for the definition of disease-modifying drugs. And this certainly means that we need drugs that prevent long-term damage, and especially also the long-term damage produced by the side effects of the drugs that we use to treat our patients, in addition to the damage produced by the disease itself, but the inflammation itself. We have already data from the first approved biological drug, from belimumab, that certainly indicates that belimumab could be considered a disease-modifying drug. But now we have also data from anifrolumab, more recently approved therapy for lupus that goes in another way, it targets interferon alpha. And these are the interim 6 months results from the LASA study, that is a multinational observational post-launch study that highlights that the use of anifrolumab managed to reach low lupus disease activity and DORIS remission during the anifrolumab treatment, and certainly shows that anifrolumab prevents the long-term organ damage compared to the real-world standard of care. This study includes 354 patients in the anifrolumab arm, where those patients that were in the TULIP trials, and also 561 patients that were included in the real-world standard of care arm. And patients that receive anifrolumab certainly accumulated significantly less organ damage, up to 4 years, compared to the patients who received the real-world standard of care. Certainly the results support the benefit of adding anifrolumab to the standard of care for the prevention of long-term organ damage in patients with moderate to severe active lupus.
And with this, we are achieving the idea that if they prevent long-term damage, how early they could be used. It was not a presented result, but just to have an idea from both of you that are experts on the field, if you are considering early biologics to prevent long-term damage, how early would be early? Ronald, do you want to just comment a little bit? What do you think? How early would be early for adding biologics to lupus?
Well, early for lupus is actually tricky because we often face very long diagnostic delay, so that when the diagnosis is made, it's almost certain that the patient already has had the disease for a longer time. And exactly how long is hard to say, because it depends a little bit on what you mean. If a patient, for example, has just one manifestation of lupus, then nobody will make the diagnosis of systemic lupus erythematosus. But then if they get a second manifestation, then a third and a fourth, somebody makes a diagnosis, but then it's silly to say that that first manifestation wasn't lupus. It was, of course, the same disease. And this process of adding more manifestations is sometimes measured in just a few days or weeks, but sometimes also in years. So we do have a category of patients who do not have lupus by any criteria, and also not by a physician's judgment, but they are, in retrospect, it's going to turn out that they did have lupus already. Before they have even the disease, there's the pre-symptomatic stage when they have autoantibodies, and we have already seen a very good study of Arbuckle and others many years ago that said that the autoantibodies are there years before they get the disease. So this is another complexity. So what is early? I think we have to be realistic. I think if you can say that the patient is diagnosed appropriately when it is possible to diagnose the patient, and that may also be not the earliest. And then when you have made the decision to treat, that you then choose a particular agent that is early treatment. That is for practical purposes. Theoretically, it could always be earlier, but that's what we are now talking about. And then the question is indeed, if you make the diagnosis of lupus and it's a solid diagnosis, right? And you know that you're supposed to treat with antimalarials and maybe use steroids temporarily, but is this already a time to start thinking about more advanced immunomodulatory treatments that include biologicals and may include small molecular agents in the future? What is the the rationale for doing it? Could it be that you're really going to prevent a lot of long-term damage, long-term consequences, and long-term costs? It's possible, but we need more evidence.
Thank you. Ricard, what are your thoughts on this?
Well, I fully agree with Ron's comments. What I think is that it's essential is not only to think early on starting these, let's say, innovative therapies, but to monitor more closely and to switch to another therapy if the previous therapy is not working. So that's probably an important lesson, that we don't have to wait for many months to see if there is a response. If you don't see the response in a few months, let's see, 3 or 6 months, depending on the manifestations, you have to take action, and then probably to change to another logical, small molecule, just classic immunosuppressive drug.
Thank you. So we don't only think that we need to treat early, as soon as the diagnosis, but also treat to target in short dates, so we can really try to get to low disease activity or even remission as shortly as possible. Thank you so much for that. Now we're going to move for some of the presentations on trials of new drugs on lupus. Ronald, do you want to comment on John Merrill's presentation of the trial of this drug, ABBV-599, which is a combination, the results from the 104 weeks of long-term extension study?
Yes, I can comment on that, but let me start by saying that there are some really exciting developments in lupus, and they're going in different categories. Because one category are new biologicals, and that's something that we've already had for many years, that several biologicals are being developed, and we've seen it in other disease areas, such as RA, and we're seeing it in lupus, where there have been 2 approvals for biologicals, and several more are in late-stage clinical development. So that's exciting, but there's 2 other things. There's also the development of cellular therapies, and I know we're going to talk about it later. But the third category is actually a number of small molecular agents that are also in late-stage development. And this is interesting because, of course, small molecular, it usually means that they can also be used as oral treatments. And that's maybe something that is attractive for some patients and makes also a lot of sense. So I think it's going to be interesting to keep that in mind. And then this is one of the small molecular agents that is now in this more advanced stage of being developed. But it didn't work out exactly as it was envisioned. The original thought was that maybe you could combine something called L-subrutinib, which is a BTK inhibitor, and that it sort of targets the B cells. And then you would combine it with upadacitinib. And of course, rheumatologists know upadacitinib as an effective treatment for rheumatoid arthritis and other forms of inflammatory arthritis. The gastroenterologists know it because it works against inflammatory bowel disease, and the dermatologists know it because upadacitinib can treat psoriasis and also atopic dermatitis. So there's a lot of different diseases that can be treated with this JAK inhibitor. Now, it turned out in the trial that was reported already previously and published that combining the upadacitinib with this L-subrutinib, it doesn't add much. So you get an effect, but you actually get it with upadacitinib by itself. And this longer-term follow-up that was presented here at the EULAR Congress supports that. So it says that if you treat with upadacitinib, you do get an effect. The additional addition of L-subrutinib does not matter so much. Upadacitinib does work, and you can actually continue it for 2 years and keep on getting the good effects. One small note is that it's at the higher dosage, 30 milligrams. So for the rheumatologists, of course, 15 milligrams is the accepted dosage for RA, but for lupus, apparently you need more. So 30 milligram upadacitinib was effective in this trial.
Thank you. And there were other mechanisms that were also presented. There were 3 presentations on dapirolizumab pegol and Ricard, do you want to highlight some of these results?
Yes. Well, there were 3 presentations defended by Eric Morin, Ed Vital, and Jonis Parodis on different aspects of the Phoenix Go. That it's a phase 3 trial on tapirolizumab pegol. That it's, as you know, an anti-CD40 ligand. It's one of the molecules of the co-stimulation between B and T lymphocytes that are essential in the mechanism of production of lupus. And the interesting results that they presented in the different 3 abstracts is that the tapirolizumab pegol improve fatigue on one side and also reduce the disease activity in patients with lupus. But I think that this is important because fatigue is a very common and debilitating symptom. Actually, for patients, is the number 1 problem. And this drug demonstrated that improve fatigue. In addition, reduce the disease activity. They demonstrated clinical improvements in using the BICLA scores and also show a high proportion of patients achieving low lupus disease activity and also DORIS remission. What we always expect in these trials, but I would like to emphasize this improvement of fatigue. I always say that when we manage to improve fatigue with a new therapy, the ones that will probably be more satisfied will be patients because they always ask for a drug that improves fatigue, aches and pains, brain fog, all these manifestations that most of the new therapies certainly don't improve as much as the patients would like.
Thank you. I have an additional question for both of you. When we are talking about results of new trials in lupus, and most of them are phase 2, but this trial, the Phoenix Go with tapirolizumab, is a phase 3 trial, and we have been several positive results. So what do you think is needed after these positive results of the trial to get it approved? So, Ricard,
well, there are several regulations. Usually, the regulatory agency requires at least 2 positive trials in different populations, using at least some slight different measures in order to get the final approval. So I imagine that the drug company probably will go for this.
Ronald, do you think that yes, this delay has anything to do with it being an open label? What are your comments on that?
No, but I think it's as Ricard says that the regulators, the EMA and the FDA, will generally require 2 phase 3 trials that both confirm the efficacy of a treatment, in addition to a safety dossier and everything else.
Okay, so we should probably wait for the second trial and then have a different mechanism working, also approved. Ronald, one of the drugs that have been also really talked about as a promise in lupus is deucravacitinib. And we had many presentations on results of deucravacitinib. Do you want to comment any of it?
Well, but I first want to agree with you that this is a promising development. So for those who are now a little bit impressed by all these difficult names, I can say deucravacitinib is actually, it's a TYK2 inhibitor, and that's actually like a JAK inhibitor. So it's sort of in the same family as the JAK inhibitors. But deucravacitinib, it's actually known as Sotyktu, as a drug, because it's approved already, not for lupus, but for psoriasis. And worldwide, it's actually being used by very many patients with psoriasis. And according to the dermatologists, it works well for that disease. But now it's indeed being tested for lupus. It had a very successful phase 2 trial, and it's now in 2 phase 3 trials. And this too, like I was saying earlier, this belongs in the category of the small molecular agents. So it's an oral treatment. It's once daily, or could be twice daily, depending. I think in the lupus trials, it's twice daily. So it's actually with a patient convenience aspect. And in the experience with other diseases, including psoriasis, it's been quite safe. And the efficacy, of course, has to still be confirmed in these large trials. And what was presented here at the Congress was, to a large extent, from those earlier trials, that the skin responds really well. So it's for patients with cutaneous lupus or with the cutaneous manifestations of systemic lupus. Those manifestations really did very well. But also in general, it seems to have promise as a treatment for lupus in general.
Thank you. And it also is on the interferon pathway mechanism. So probably not only, but
yeah, that's a good point. So the question is always, well, a JAK inhibitor, or in this case, the TYK inhibitor, what does it really do? Yeah. And interferon, the type 1 interferons, they signal through a molecule that contains TYK2. So you could say that this is really indirectly also a way of blocking the interferon system. And that may be the main mechanism. It's quite possible.
Thank you. Then we chose 2 other agents that had been presented also in EULAR as new. So, Ricard, do you want to comment on the phase 2 trial using the oral TLR78 agent?
Yes, it was an abstract presented by Eric Moran. It was one of the late-breaking oral presentations, and it refers to enpatoran. Enpatoran is an inhibitor of the toll-like receptor 7 and 8, and this is certainly a novel mechanism of action of drugs for lupus, but it is also related to the interferon pathway. So this is another way to interfere with the interferon pathway. And well, this was a phase 2. What we can say is that enpatoran was well tolerated, exhibited nominally significant improvement, measures of lupus activity throughout the week 24 compared to placebo, and also demonstrated that it works on that it interacts in the interferon pathway. So far is what we can say from this phase 2, but again, this is a promising pathway, or a promising pathway that can be targeted in lupus.
And it's also oral.
I might add that it is another small molecular agent. So like I was saying earlier, it comes in that category. But this is a bit earlier because it's in phase 2, and so it still has to go to phase 3 development. I think another one that is small molecular, but that is now in phase 3 is cenerimod.
Yeah.
Cenerimod is an inhibitor of, don't get scared now, the sphingosine phosphate pathway, and it's also usually abbreviated S1P1. And that is already a target in the treatment of some other diseases, including multiple sclerosis and also inflammatory bowel disease. And it works through telling the lymphocytes to travel in certain directions and not in others. I'm not going to try to even explain the details here, but it has to do with the trafficking of the lymphocytes. And like I said, it's effective in some other diseases. In lupus, it was already in phase 2, and now it's in 2 large phase 3 trials that could actually be completed this year. So it's moving along quite readily. What was presented here at the Congress was more from the phase 2 trial, and certainly seemed to support the efficacy and also the sustained efficacy if patients continue that treatment. So another small molecular agent that is looking promising.
Yes, it's good. And we are almost finishing, but I think that there is not one of our episodes on the last months that we are not talking on cellular therapy for lupus. And I was amazed. So many different molecules for CAR T cell, CAR-T with T, CAR with NK. So, Ricard, can you please comment on this huge amount of different molecules, and is this going to be for a particular subset of patients? Are we going to use it widely? What are your comments?
Yeah, certainly it's amazing how just the preliminary results of 5 patients that were published less than 3 years ago has generated so many expectations, so many trials, dozens, more than 100 trials in lupus and related systemic autoimmune diseases just in this little bit more than a couple of years. And nowadays what we are seeing are these variations. It's interesting is that in addition to the classic CAR T cell against CD19, that were the classic first CAR T therapy developed and used in the first 5 patients with lupus that were published in Nature 3 years ago. Now we have seen in this Congress the presentation of allogenic CAR T therapies. It's off the shelf, so this will address the limitation of the autologous CAR T cells that we have so far, and certainly the difficulties in the manufacturing and the times and the high cost of this. And also it's interesting that we have already dual targeting. So not only targeting the CD19, but also BCMA that will target the long-lived plasma cells that CD19 doesn't target. So it's a new area. Certainly, probably these post-CD19 CAR T cells are really promising. Which patients probably will benefit of these therapies? Well, so far probably we have to think on the refractory, severe lupus patients. But if the research in progress makes some CAR T technology like similar to the biological order of small molecules, maybe this will be expanded to the majority of the patients or to a great proportion of the patients. So at this moment, we are probably in a bridge between the expectations and the realities that hopefully, if this goes quickly, as it appears to be, we will have probably, let's say, 5 to 10 years.
Arnold, what are your comments on it?
Well, I mean, I totally agree, but I think it was important to note at this Congress, as you already said, there were very many presentations on CAR T cells or other kinds of CAR cells, on alternatives based on other technologies. But we were also hearing some results that were not so good. Yeah. And this is what always happens, with a new treatment. First people say, oh, it's fantastic. And then slowly but surely also the reports come that, well, it can be very good, but sometimes also not. So there were patients who had been treated with something like this and they flared. There were some serious side effects, and there was, of course, also discussion which we already had about the cost and the appropriateness for certain patient categories. So I think what we still need to be very realistic here and say that as it stands now, CAR T cell therapy and other cellular therapies that have the potential of being breakthrough, but that's because for some patients they can maybe achieve long-lasting remission or even a cure, but they're not going to achieve that for all patients. Yeah. And then for some patients, they're also going to achieve side effects. So we need to be very careful. This has to be studied more. We face the problem that so many trials at the same time is difficult to do. The centers that can do the trials, there's not so many, then they cannot do all the trials all at once. So it's a complex mix, and the regulators play a role in this because the EMA and the FDA will have to tell the companies what is needed to get a drug approved. But the regulators, they do not have the possibility to develop the outcomes. So the best outcomes for these studies and for these trials, they have to be developed by us in the academic world. And so I'm very pleased with the TRM SLE project that's being led by Eric Moran, but I'm also very happy that with the DORIS task force, we are now going to develop a definition of remission that goes a bit further than the clinical definitions that we already have, and that will incorporate some of these elements of very long-lasting remission, of treatment-free remission, and of immunological reset.
Thank you. Ronald, Ricard, do you want to add any final comments on this Congress?
Well, we will never be in a beautiful city as beautiful as Barcelona again, but next year we're going to be in London, which is not bad either. And I think that a year from now, when we talk about the next EULAR Congress, there will have been, again, so many new developments that we'll definitely have to have another podcast for that.
Yeah. And it was so hot in Barcelona also. So hopefully London will be not so hot next year.
As long as it doesn't rain.
Ricard, do you want to add anything?
Right. Yes, that's right. Well, we think that we are having great expectations for new lupus therapies, and I am sure that next year, some of these expectations, we will see some realities, but more expectations probably will be generated. So it's a good time, I hope, for lupus research.
Ronald and Ricard, thank you so much for joining me today and sharing your insights. To our listeners, following a busy few months at the congresses, we hope these discussions from EULAR 2025 have helped you clarify the latest in lupus research and clinical practice. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.